So I suppose when we talk about transitions of care, there's sort of two things that come to mind. We've talked a little bit about transitions between different anticoagulants. In fact, that's been a big part of today's discussion. But there's also transitions between all the people that are involved with your patient's care for that patient that's on anticoagulant. So we're talking about transitions of care. So we've seen this one before, so it doesn't really need a lot of explanation. We're all aware of the different types of transitions that we could have. But I suppose what the message is what happens when we decide to make these transitions? Who needs to know? How are we going to do that? But also, with the anticoagulant transitions, we could also say, okay, we want to transfer between warfarin and a DOAC, one of the NOACs, or a NOAC to warfarin, and how are we going to do that? So we have to know what we're doing. We have to be aware of what is the process and what's going to be safe for our patients. So with transitioning from warfarin to a NOAC, we can just wait till the INR comes down to below 2. But in some cases, like if we're going the opposite direction, we might actually have to do an overlap and stop the NOAC when the warfarin and the INR's over 2. So we need to know these processes of change are not complicated necessarily, but I've put this up because there are different things in different situations, and we can get ourselves into trouble, but it's very, very important to understand what we need to do, and expressing that and telling the ongoing people that are looking after the patient.
What's VKA?
Vitamin K antagonist, so warfarin. Okay. So what have we got available to us that can help guide us through these processes? And we have good guidelines. There are good guidelines, and we've talked about online references and things. But also, if you're unsure, phone a friend. Phone the thrombosis service. Phone your pharmacist. Phone thing, and we can help talk through it and work out an appropriate. The pre-assessment nurse might be ringing you and asking you. GPs might be asking what's the process. And again, someone said earlier, we don't actually think that the surgeon wants this, but we don't actually think is that absolutely what's appropriate. So again, ring them and ask them, consult, and then after we've got a good plan, document it so it's written really well, so everyone knows what's going on. So and the patient particularly might need it in more than one form of interaction. Whereas with transitions of care, as you can see here, there's a lot of people that can be involved with your patient that's on an anticoagulant, and they might be going to the GP. They might be going to the GP, or they might go direct to the hospital. They might be going to the pharmacy, or they're going from the hospital to aged care. They've got some sort of community support perhaps. They've got home visits or secondary care visiting them at home, or they've got primary care nurses going into their home, or we've got even to and from palliative care. In all of these situations, there should be really good transfer of information about and documentation about what's appropriate for that patient, what's the plan, how can we do that? These are just some of the things. There's probably more, but I've come across we have GP referrals to the hospital. We have outpatient clinic letters, so they go back to the GPs through their system. Rest home admissions. That can be a little bit fraught with what exactly is going on. You might get partial information. You might not get a lot. Often we get the drug chart to say they're on warfarin. We've got no idea what their current dosing plan is. If you're lucky, you might get all of the drug charts so you can see maybe the new additions. So sometimes there can be incomplete information comes in from the rest homes. Conversely, discharge summaries can be very full and very, very informative, and others can be pretty bad and very quick. And I know surgical house surgeons are under a lot of time pressure to discharge their patients and then readmit other patients, and their discharge summaries aren't always as complete as they could be, and particularly with warfarin, it's a good idea to know exactly what's been going on with the patient. Ward to ward and specialty transfers, even that can be a little bit horrific at times, and then you might end up with a whole pile of notes and you have to go delving through the notes to find exactly what's gone on. And then we have facility to facility transfers as well. So we've got multiple areas where we need to be able to have good information sharing. What sort of information? Which anticoagulant? Indication and length of treatment. Sometimes that's hard to find out even. How long have they been on the warfarin? What was it for initially? Sometimes we've had people come in on dual antiplatelet therapy after their stenting, and they've been on their clopidogrel for miles longer than they really need to be. What's their current dose? Relevant tests, INR and creatinine, and this is something in secondary care we find hard, a little bit more difficult, because although we've got access to GP records, the ones that are involved in community and shared care, in aged care facilities, aren't always put into the same system, and certainly the GP's records for that patient aren't necessarily up to date because the records are held actually at the facility. So some recent histories would be really useful. Recent changes to meds, recent problems. This is either direction. It's really good to know. Ongoing plan for dosing and testing, and who's looking after the anticoagulation. It can be a little bit airy-fairy at times. If we're going to ring the GP or ring a surgery, or we're going to ring an aged care facility, who do we actually need to tell about what's going on? Sure, they get a copy of the discharge summary, but as I'll show you, that's not always the best. Just don't assume everything's in the discharge summary, I suppose, is the message. So one solution we came up with at HUT, and this is quite a few years ago now, and the problem arose when the CPAM pharmacies started. We had 5 in the Hutt Valley. We've got 5 in the Hutt Valley, but there was at least 2 that were on the initial group that did the pilot. We had patients coming into hospital who we knew were on warfarin, but there was no INA testing. The GP records didn't have an INA test in their system that we could access. The hospital records didn't. We thought, what's going on here? And of course, the only person that actually knew was the CPAM pharmacy. Of course, it's 10 o'clock on a Friday night, or it's 9 a.m. on a Sunday, and they're not open. So where do we get that information from? So it evolved over time, but we always had this drop-down section here in the discharge summary, patient initiated on warfarin or altered maintenance dose, and the house surgeons are educated to fill this all out. So there's a nice lot of history given about if it's initiated, what's it for, how long for, what the current dosing's been, what the test results are, what brand of warfarin, who's going to be managing it. And on the discharge summary, it comes out like this. Not necessarily quite the same format for the GPs, unfortunately, but it is quite legible, and it gives you quite a good succinct summary. So that was one thing. We already had that, but we had to add who was looking after it. We had to add the CPAM. We added the CPAM pharmacy onto the checklist. because it was important that was also another mental reminder that, CPAMs managing the warfarin will ring them and let them know what the problem is. The GPs will still get the discharge summary, but we'll ring the CPAM pharmacy. And then we started an alert system. So we put these alerts in on Concerto, and you can see this one's back in 2014. The only downside of this is it has to be put in manually and it has to be reviewed manually. So there's a couple of us in pharmacy that get a list of all the patients, and we update this alert about every 6 months to a year, just to keep it up to date. And then we deactivate some of the alerts of the people that aren't, I add the new ones in. So unfortunately the two systems don't talk to each other in that respect. But we do have now the point of care testing. When they go to the CPAM, an email gets sent to the GP with the test results, but it also gets emailed into our Concerto system. So we can actually see here that it says INR CPAM, INR online. So we know then that is actually a CPAM patient. We know from there, we can say when it is, and if we drill down, we can find out what the next test was, any little notes that they've made in between that. So we actually, these results get then put into collation historically, date-wise, so they just get added into that ongoing INR timeline that we have in our system. Discharge summaries. How good are we at documenting? So I did this as a bit of a review, and I reviewed 142 discharge summaries. 53 had stopped for a variety of reasons, and they were pretty good at documenting why. There were quite a few that had message to the GP and message to the patient for discussion with the GP at a future date about restarting. So it was stopped for a variety of reasons, and some of those might have been bleeding, some of it might have been for a procedure, or so they were varying. That warfarin on discharge section, however, was only used 53% of the time. So that lovely section where we can put all that information in half the time. When it was used, the CPAM or GP indication of the plan was only in 20% of them. Still pretty bad, really bad. Some dosing plans somewhere, about 89%, but you had to go digging for it. And sometimes it was advice to the GP, sometimes it was in the advice to the patient. And this doesn't take in any account what the patient was actually told at the bedside on discharge. So we've got had no idea of knowing exactly what was going on there. So we still have a little bit of work to do there, but it can just say documentation of ongoing plans is really, really important. And we're fortunate that the hut pharmacies have licence to online link into our Concerto discharge summaries. So if they know the patients have been in hospital, they can actually go in and read the discharge summary. And prior to that, they had problems where they didn't know what the plan was, and they could have followed up on a blood test and didn't because they didn't know about it, and the patient had an adverse event. So to have that linkage in with the CPAM pharmacies we find extremely useful. And I encourage the house surgeons, if they're going to make a call on discharge, I encourage them all, if the patients have had problems in hospital, they need ongoing monitoring, they need an INR soon, they call a GP, they call the anticoagulants, they call the CPAM pharmacy. So if we don't, they can easily fall through the loop. And patient education, that's also part of the transitions, and I'm sure Alison might talk a bit more about that. But there's lots and lots as we're all different health professionals, but we're all involved with care, and we're all able to be involved with the education and have opportunities at multiple times to be able to check what their understanding of their warfarin and their anticoagulation is and work through any issues that they have. So there's many opportunities along the way. We just need to remember that when they're unwell, information retention is poor. and health literacy can be an issue, so just be careful. Not related to warfarin, but methotrexate recently. Community pharmacist dispensed a prescription, counselled the patient's husband about when to take it, how often to take it, how many tablets once a week. He relayed it back. She didn't start it for 2 or 3 weeks, and she took 4 tablets on 5 consecutive days and ended up, fortunately, with not too many adverse effects. But I got a call on Easter Saturday. What can they do? You know, what can we do as an intervention? So these things, health literacy, making sure that their understanding's good, tailor-making education to people that might need a different way of learning sometimes helps. But just being aware that everyone's needs are different, and we can, that's it.